Part 9 of Neuro is about neural tube defects. These defects include spina bifida, omphalocele, encephalocele, myelomeningocele. The cause of them we don't really know, except there is an increased incidence in developing these defects when the diet is very low in folic acid. The neural tube develops and closes by the 4th week, and so this is a congenital malformation. It affects the spinal cord as well as the vertebrae. The most common spina bifida is below the L2, and then these kids have decreased sensation as well as paralysis below the lesion. It can be associated with other anomalies, including hydrocephalus, club foot, contractures, and scoliosis. This picture shows you the variety of spina bifidas. The occulta, you can see there's not that much in terms of the nerves being involved. We do see a hair tuft, so we're watching for this in our newborn exam. When you see a meningocele, there are still no nerve roots that are within that little sac, versus the myelomeningocele, you can see those spinal nerves are all coiled up in the sac. And both of these sacs, the meningocele and myelomeningocele, are outside of the back of the spine. And so we see that bulge on the back. I have some pictures later. So an occulta is incomplete fusion of the vertebral bodies. But like I mentioned, the meninges are fine, the cord's fine, the CSF is fine, nothing is protruding through. So we may see a little dimple or a hair tuft. There really is no neurologic sequelae as a result of this, but a person could have backache as they age. Versus the meningocele. You see that big bulge between those two vertebrae? But once again, all that's in here is fluid. There's no nerve roots. The myelomeningocele has a lot of nerve roots, and this looks like it is about L4, 5, and then we have our sacral vertebrae below it. Here's a picture of a myelomeningocele. You see all those nerves that are stuck in there. And get ready, because now we're going to see some real children. This is a child with a myelomeningocele, and it's starting in the thoracic vertebrae and then going into the lumbar vertebrae. And if you look very closely at this child, it almost looks like he has what we call an imperforate anus. And you can see the little hair tufts along the line where the vertebrae are as well, and a smaller tuft just above the big lesion. Here's one that's lower in the spine, and it doesn't look as bad as that first one. This one is very, very large. We don't want this to rupture, and so what we would do is cover this with sterile 4x4s that are moistened with normal saline, just to keep the tissue viable. But this kid is going to go to the OR very quickly. And here's some more pictures. So that's full of fluid as well as nerves. Now this picture is the encephalocele, and so it's the same principle where the meninges, the nerves, and the CSF are all protruding through this sac. We have a child that is at Altamed that we're caring for that had this defect. So the myelomeningocele is the worst form of spina bifida because it doesn't include all the nerves, the nerve roots, the meninges, as well as the CSF. So infection is a high risk, and they have decreased mobility. So if it's going all the way to T12, the lower extremities are going to be flaccid. They don't feel them as well, and they don't have any sensation of bowel and bladder control. And so they have incontinence and dribbling, but they also have urinary retention because they can't tell their bladder is full. If only L1 and L2 is affected, then that's going to affect the hip flexion as well as the feet, where they may seem like they have foot drop. L2 through L4 affects hip adduction, so they're not able to lift the legs up to the midline. L3 to S2 is more of the hip adduction as well as the extension and the ability to flex the knees. S3, it doesn't affect any motor, it only affects sensation. And then if the sacral root is affected, then that affects their ability to do plantar flexion. Now, you don't have to memorize any of this stuff, but it's just very interesting if you get into neuro as your specialty. Most of the kids who have this myelomeningocele have what we call a neurogenic bladder and bowel, because they do not have the sensation of needing to void or pass stool. We can diagnose these neural tube defects prenatally through the AFP, and you'll learn that in 174. We can also see it on a maternal ultrasound. But there are going to be some women who come into OB, into labor and delivery, with no prenatal care whatsoever, and so we can be caught off guard and a complete surprise. When we manage these type of disorders, we have to assist the family in dealing with this diagnosis and realize that any surgical procedure that we do for these kids is not going to completely correct the defect. This child will have lifelong defects. What's interesting about these defects is the high incidence of latex allergy associated with this condition. So when we do their bowel and bladder care, when we're doing any dressing changes, we use latex-free gloves. So the myelomeningocele and the myelocele will need a surgical closure in the neonatal period. So they have to stabilize the child, and as long as they can be put under anesthesia safely, then they'll take them to the OR. So we want to keep them in a prone position with their hips flexed as much as possible and protect this whole sac from urine and stool. Do watch for signs of increased intracranial pressure because they can have coexisting hydrocephalus with it. Monitor them for infection, remembering that the neonate does not mount a fever response, so it's going to be their behavior that's going to tell you that they have an infection. Post-operatively, we're going to position them very similar to what we did pre-op. And the next slide is going to show you what the post-op incisions are going to look like, and will protect the site from bowel and bladder contents. And so here it looks pretty good, doesn't it? Then our ongoing management is we need to put them on some type of a bowel and a bladder program because they have stasis. Stasis leads to reflux. Reflux leads to UTI, and it also leads to hydronephrosis. They need to be taught how to do catheterizations because they should be catheterized every 6 hours. For bowel, they have a propensity for developing constipation as well as a fecal impaction. So we put them on the bowel program that includes stool softeners and rectal stimulation, putting them on a toilet when they're old enough to sit so that gravity can help pass stools. We also have them on a high fiber diet and lots of fluids. Protect their skin from urine and stool as well as pressure because they cannot feel when they might be getting a skin ulcer. Orthopedics gets involved to help correct any of the extremity issues, occupational therapy and physical therapy as well. And so these kids might need to be put in braces and then learn how to walk and function. There is developmental support for the family as well as the child and follow-up care through the Spina Bifida Association. And this last slide shows you that these kids can lead a normal life. Just because they have the disorder, notice I never once said that they are cognitively impaired. It can be, but not necessarily. And this ends the lecture on neural tube defects.